This is Me, I Am Mental, the podcast. A quick disclaimer. The content you find here is neither intended to be therapy or diagnosis. It is provided for educational, informational, and entertainment purposes only.
Welcome to Me, I'm Mental, a podcast where we discuss all things mental. Our aim is to provide factual, credible, useful, and engaging information on mental health. My name is Charles Adede. In part one of this conversation with Rhodah Kithure, who is a clinical psychologist, she began by sharing her personal experience of living with her late brother who suffered from mental illness. Her experience, though harrowing and ultimately tragic, influenced her decision to pursue a career in mental health. We then proceeded to discuss the difference between mental health and mental illness, and whether there is indeed a mental health crisis in Kenya and globally. We touched on some of the serious challenges facing individuals affected by mental illness, including general lack of awareness and support for them. We also generally agreed that there is need for every person to pay closer attention to their mental health and that of their near and dear ones. Now, welcome to part two of the conversation. Now, Rhodah, I think a very critical thing for many of us, and our audience as well, I'm sure, is to also get a sense that if we need to develop the life skills required to manage our mental health, we need to know the risks that we face in terms of mental health challenges. And generally speaking, we need to know what are the common illnesses or challenges that we can mitigate by ourselves by doing the right things with our lives, and some of which are really things we can't control or manage and need professional help. And at this point, it would be a good thing for you to just highlight to us the most common mental illnesses that affect us and what the causes are. I mean, some are, I'm sure, genetic causes, some are environmental, some therefore would mean that we can, to a point, manage our lives and avoid them. And some, it's just when you're in that space, you just need professional help. So some guidance around that would be a good thing.
Okay, let me start with some of the common mental illnesses we have. We've been talking about depression a lot. We've been talking about anxiety disorders. One thing is depression, we consider it as a mood disorder because it affects our mood. You find when you're sad every time and you've lost interest, your mood is changing. You're like, okay, this is a point of concern. This is not based on maybe a change in hormones. No, this is something which is continuous and it's been going on for the last couple of months. So that's why we're putting depression. We have bipolar, some of the common diagnosed illnesses right now. And now I'm looking at, even in Kenya, I'm going to go globally. We are looking at attention deficit disorder, hyperactive disorder, ADHD, which is something which is now you're seeing it, even the diagnosis, it's like more and more people are presenting with such. We are looking at post-traumatic stress disorder. This is something where after you've gone through a traumatic event and afterwards, and it's not addressed, the aftermath of that. We are talking about schizophrenia. We have talked about schizophrenia a lot. And then the substance use disorder, where we are not talking about, these days we don't call it abuse because it's an illness. So it's disorder. So we have drug use disorder. We have now even behavioral addictions. And this is where we are bringing sex addiction, gambling addiction. It's not yet labeled internet addiction, but we're realizing it's there, something which is there. So we have that. And then we have others like even eating disorders, which are there, something like bulimia, anorexia. We have, people use this term a lot, OCD, but it's obsessive compulsive disorder. which it's even more associated with anxiety a lot. So it's a disorder itself. There's a way people say you're so OCD, but now we have a disorder now, which literally impacts your life negatively, even functioning. So these are the common ones you find. But also we have others. There are so many, but these are the commonly diagnosed and commonly people are being affected by this. And you'll find linkages in some of them. You find someone who has depression and also has anxiety symptoms. So in some way they interchange. And all of them, one thing is the symptoms, we have evidence of symptoms of depressive symptoms in all of them. That's why we don't say you have depression when you're diagnosing. We say you have major depressive disorder because it's a disorder. So depression is a symptom. Yeah, so when you talk about depression, you're calling it a symptom you find in bipolar, you find in anxiety, you have depressive symptoms, you find in schizophrenia, you have depressive symptoms. But now as a disorder, it's major depressive disorder.
So you keep using the word disorder.
Yeah.
And I want to understand, can I be depressive, but it's not a disorder yet?
Yeah.
And how do I know when it becomes a disorder?
That's when now we say you need to go seek help, because when someone is as a burnout, or you're fatigued, you present with depressive symptoms. When you're going through grief, some symptoms mirror depressive symptoms, even prolonged. So you have to go see a mental health practitioner, because you can't go diagnosing yourself, because this person has been trained to assess you and rule out and understand what is the disorder you're struggling with, how is it impacting you. So you yourself, you can't diagnose, but for you can realize at the point I've gotten to, this has gone long enough, because for us to diagnose with a major depressive disorder, it has to go to almost close to even 6 weeks past. You're experiencing the same symptoms continuously. And then if it has gone for even a year, it goes to another different kind of disorder, but still you're presenting with depressive symptoms. So someone a trained mental health practitioner is the one who can help now know, is this a disorder, or you're going through something, a phase in your life, a change in your life. Maybe you've lost your job and you're presenting with depressive symptoms. Maybe you're undergoing through stress and you're presenting with depressive symptoms. But we can't go to calling you have depression. No. We can't go saying, do you have? No. But you're presenting with these symptoms. So the work of the practitioner is to know what actually is going on.
So when they do, for instance, a near and dear one has passed on,
yes,
and I'm grieving, and I've been grieving for a while and beginning to think, maybe I am not managing this very well. And I come to you, and we sit down, and after a while you reckon it's not yet depression as a disorder.
Yeah.
What happens? How do you manage me, or what do I do?
So the first things is when you come in and you're realizing you're going through grief. So this is now where I handle it as grief, because I've assessed everything else and there's no evidence of any other disorder. It's grief you're going through. Mm-hmm. First things first is you have to identify what's the kind of support system do you have around you. Because for any kind of, even any challenge you're going through, support system is very critical. Because you alone, it's even detrimental to your recovery. So we have to look at the support system. We have to look currently, how are you coping? What are your coping mechanisms? It's very critical. And then now, I help you now managing the simple tasks you can do. And then also through that, we have to look at the memory of what will the kind of relationship where this person was past. And then now, I help you now go through that process of healing when I know already you have protective factors around you. By protective factors you're looking at the support system. We're also looking at financially, how you're coping with this. We're looking at either you're working or you're in school. What is going out? So we ensure, but as you're going through this healing process, we're ensuring your system now around you, you have protective factors to support you as you're going through the treatment. So that is one key thing. But support system is so critical. And sometimes it's not be family, can be friends, but if you have no one to say you can reach out when you're going through something, that even now it's worse, because now that shows isolation, that shows you can't even talk to anyone. So we have to identify why are you all alone? What is going on in your life? So I help you now in creating those relationships now, rebuilding maybe relationships which have been lost. So there are different ways of how you work with each and every client presents differently.
So we have the situation where I'm presenting with depressive symptoms. Maybe in a way there's hope. There's more hope for me to, in terms of being managed and getting back on my feet, in terms of my mental health. But for a person who has a disorder, my assumption is that that is a more extreme case.
Yeah.
And when you get to a point of having a disorder, then even your chances for getting better are that much less. Is that a good assumption to make? The point I'm trying to make again, if we focus most of our attention on preventing ourselves from getting disordered,
Yeah.
then we'll be mostly in a better place.
Yeah.
Isn't it?
Mm-hmm.
So the assumption is by the time you're disordered, now things are beginning to get really thick for you.
Yes.
And so against that assumption, if I present and you actually diagnose me with a disorder, say in this case, depression, what do you do with me?
When that happens now, I have to assess and see, are you at a point where there's a need for medication? Because there are some cases where medication is critical. If there's a need, then now the next phase is I refer you to a psychiatrist. But I have to assess and see, can we try first therapy and see if you can function? Because we need to get you back to a place where you can actually function in the society so well. You can be able to cope with day-to-day activities. You can be able to organize yourself and your life. So I need to get you back to that phase. So we can try therapy, we assess and see, do we start with therapy or do I get to a place where it's so severe, I need to get to you to a level of you need medication? Because it's critical and the medication is to help you now get you back to, we'll still continue therapy, but the medication is necessary. So I have to assess at which point I say, right now I need you to go see a psychiatrist and I refer to a psychiatrist. But in the process, you still continue therapy based on the severity. But now we have to assess based on, is it mild depression? Is it moderate? Or is it severe? So the level of severity matters if you need medication. So if you need medication, you have to go for that. If it's therapy, we use different techniques which will align with, can help you get better. So that is at the level of extreme treatment. So when you're talking about prevention, this is where now we bring in the factors which predispose you. That's why you're talking about now, what are some of the things which are risk factors to you? We are talking of genetics. If there is any family member who has a history of mental illness, that now it's a trigger we have to look at. Because if there's depression, there's schizophrenia, there's someone who's diagnosed with bipolar or substance use, that means you're vulnerable, you're susceptible to that. We are looking at life experiences. Have you gone through any traumatic experience? How did you cope with that? How you deal with it? That makes you more vulnerable. We are looking at history of substance use, even for you. And now you're presenting with these symptoms. And then I look at your history. There have been history of substance use and it has impacted you negatively. That is another risk factor. We are talking about chronic stress. We are talking about if you have undergone such a period like that, leaves you vulnerable to mental illness. If you've grown up in a home where there is evidence of violence, divorce, you have gone through a adverse childhood experience, leaves you vulnerable. That's a risk factor. Medical condition, you have diabetes, you have cancer, you have HIV. That also makes you more vulnerable. And then social determinants, you're looking at lack of access to resources such as healthcare. We are looking at poverty levels.
Yeah, I mean,
Yes.
is being broke like...
Yeah, it makes you vulnerable. Yes, it can make you vulnerable. Where you can't even afford basic needs, that makes you vulnerable because now that makes you're being brought back to that survival mode. And
Yeah.
you're forever stressed because where am I going to get the next meal? Where am I going to get a shelter to live on? Am I going to get access to treatment? Can I feed my kids? So your brain is highly stressed.
Well, yeah, because you keep talking about how a support
Yes.
system or lack thereof
Yes.
is a risk factor. But I mean, just for the common guides, it's like being broke is also a lack of support.
Yes.
Like you can't support yourself, and I think that would just be a huge risk factor. I mean, not to say that if you have wealth that you don't have that risk factor, have risk factors, but it must be huge.
It must be huge. It's very, actually, when they brought in this aspect of advanced childhood experience, so this doctor was treating, she's a pediatrics doctor, and she was treating people from settlement areas, let's say, for example, like Kibera, that. So, and this was in States, and she started seeing cases of ADHD symptom, like many cases were being presented of ADHD, and she got worried, why are there so many cases of this? And then now, that's when now she decided, let's dig deep and understand why so many people from this region, this area, they're struggling with this.
Chronic brokenness.
Yeah. When you put it that way, yeah, but that's the case.
Yes.
Because now you're lacking basic needs.
Yeah.
Or even in the homestead you're growing up in, you're constantly in the struggle of where am I going to get? So even your brain, even the brain development of the brain naturally is not happening. So you're stuck in that place where the child is survival mode.
Yeah, you're not planning ahead anymore. That whole process is irrelevant.
Yes.
Planning ahead isn't helpful.
Thank you. So you're thinking of what tomorrow, what's ahead. Tomorrow, you're not only thinking of tomorrow, thinking of the future. So meaning development-wise, learning development affected. So by the time you're going to present, your symptoms are presenting as ADHD, that's actually not the problem.
Yeah, you're not ADHD. Yeah. You're actually just figured out how to live.
Yes. So that is how now you're coping.
Yeah, maybe you're both, but yeah.
So that's how it's presenting. So that's why even they put in like poverty, it's also a risk factor. Doesn't mean that just because you've grown up in poverty makes you develop mental health symptoms, but the thing is, it's a risk factor, makes you vulnerable.
Sure.
Because you don't have access to healthcare, even any support, it's not there. So that makes you vulnerable. And then finally, the one thing, chemical imbalance in the brain.
Sure.
That is there.
Yeah,
even hormonal imbalance.
You could be born that way, but are there triggers that will flip that where it can occur later in life?
Thank you. So these are factors which makes you vulnerable. So one thing, when you come in, we assess for all these. Good. That's why even the first session in therapy is not, we're not really looking at this is the problem, this is the treatment. No, we have to put all these on board. We have to assess all these. It can take even 2 sessions for me to check out all these, because I can't rush to diagnosis and there's something else which is triggering these symptoms. So I have to identify what is making you vulnerable. Let me understand you biologically, psychosocially, psychologically and socially, spiritually. I have to understand where you are at. And then now from there, that will determine now the diagnosis I'm giving afterwards.
So I had this interesting experience where I went to a hospital and I'm asked by the doctor, so what brings you here today? And I say, I think I'm depressed. And the doctor seemed to go with that. Like they seemed to assume that my diagnosis of myself was fairly accurate, and then we sort of proceeded along that. What I'm saying is, what you've shared with me now doesn't mirror my personal experience, because then we generally focused more and more on that area. There wasn't a lot of digging into my background and all these things to establish, is this indeed what this guy is suffering from, or could there be more? And now that you say that, it makes me wonder whether I missed something. Maybe not.
Maybe not, but as you said, you presented what you know, and the doctor went with that. So, maybe missed something in checking what presented. And because many people right now, we understand when people go for therapy, they won't commit for the sessions fully. So the doctor sometimes have to work with what is presenting right now, and I treat you. So by the time you're leaving, because they know, even we are told even committing to 6 sessions, that is That is even, not many do that.
It's probably as hard as getting people to finish their round of antibiotics.
Thank you.
Yes, isn't it?
Yeah, so
I'm better.
you're good, so you leave it. But you realize now with time when you don't complete the dose, it comes it's the same thing.
It has a long-term effect in your ability to cope.
The same thing happens here. When you don't complete, you get to a point of, I'm good. And then a year later, you come back and you're back to where we started again. And you have to find what is happening. Because it's like, I usually relate it like this. You come in, you've been coping, but it has gotten to a place where you feel, I can't cope anymore, I need help. And then you come, we peel that off, that wound, and we identify where the problem is. And then you decide, I'm good now. So it's like the wound is just there now, it's there.
It's a scar. You've just covered it.
Yes. So it's
festering.
It's festering, eating you inside slowly. Because now I've already opened. We are already what you've been using to cope is not working anymore. And now we've just covered up what to do, and it's festering, eating you up slowly, years long. And then later you're coming, why didn't I get better? You didn't finish the treatment.
I have an interesting, I guess is also just a thought around sessions. So your typical therapy session is about an hour. In Nairobi, maybe to access your therapist, if you're living on one part of town and the therapist is on the other, that's maybe 2 hours of traffic one way, another 2 hours of traffic the other way. If you're working somewhere, it means that every time you're going for therapy, you're probably seeking a minimum of half a day off.
Yeah.
And not to mention the other inconveniences, including the financial implications of seeking therapy. I can see why committing to maybe more than 3 sessions of therapy is a stretch, and why then people do some sort of shortcut with obvious detrimental effects. But it's very, that's heartbreaking. It's heartbreaking to see that this person's life is in some ways on the line, because if they don't really fix this, if they don't fix it properly and comprehensively, it's just a matter of time before they come back. And even whatever effort and resources they were trying to save by not going through with the entire process, they're probably going to spend more. It's going to catch up with them, and it's going to devastate them at the point it comes up again. I think that's terribly sad. I don't have a real answer to it. I don't know whether anybody does. I don't know whether you have a way around it. But it's just that when all these factors come together, it paints a very dim picture for people who are then at that point where they really need intervention. It becomes very tough for them.
It is all that. I like last year. I don't know if it has been implemented yet. The president said about rolling out a universal health coverage, and NHIF was mental health coverage was included in that. I don't know about if it has been implemented yet. So when it comes to insurance coverage, that's a big challenge. You find workplace, yes, they're covering, let's say you're employed, that is covered. But what about this person who is not employed and who is struggling? And already you have noted poverty is one of the critical issues. So you find this person from rural areas or even in Nairobi where you need to seek help and you don't have that access. And also for us as mental health practitioner, for me, yes, there's a point I would offer pro bono, but it takes a toll on me. Because you can't just be doing pro bono, because you have to pay the bills, you have to continue with education, which costs. You have to live and sustain your life. So you can't go offering pro bono every time. So you find that service is very limited. But now, I don't know, comes to these referral hospitals, that system is rolling out, but the cases are on the rise. You find even the psychologists employed there, they're overwhelmed because the case is on the rise. So the challenge is there on the treatment side. And as I opted for what can we do, as you said, prevention. We have, right now, in Kenya, things are changing since COVID. We have people who have gone through therapy, they have a lived experience. Someone decided, let me speak up for for people to know you can go through this. It's something which is changing the system right now, because we have mental health champions. They're called champions because you've had a lived experience and you talk about it so that people can feel comfortable to speak about what they're going through. And the more you speak, the more you feel, I'm not alone in this. This is another prevention method.
Yeah, it seems like communication would be a huge aspect of just preventative care, just putting it out there in the open, but also just it feels like having quality relationships, friendships, and family situations that are conducive to actually being able to talk about it is also another cofactor of prevention. Like talking about it and having someone to talk about it with.
Yeah, that's why it's very key. Even from the first session, the one thing you ask is, tell me about your support system. Because even though I treat you, you're coming for treatment and you don't have a good support system, this treatment, for it to actually be effective, it's very low. Because when you go there, who can you talk to? Do you have someone you can share with apart from me? So who do you trust?
Yeah.
So hence now we are having issues of many more people saying, yes, I have friends, but I'm feeling I'm alone.
Yeah.
I can't talk to anyone. I can't speak to anyone. And everybody's asking, this person was so happy. Why did they kill themselves?
Yeah.
Why did they die by suicide?
Yeah.
But the thing is, this person, the more we are with people, the more I'm feeling alone. And it's becoming a very common scenario among many people, because that is not there. So one means of prevention is having people you can trust, a community you can speak about it, creating more and more avenues of communication like this one, where we can comfortably talk about what is going on with us.
I just wanted to, around the question of your abilities as professionals who are providing assistance to affected people. You, for instance, in a day, optimally, how many people can you see?
To be effective and offer the best support, I can say even a maximum of 4.
Wow.
Yeah, a maximum of 4, but sadly that is how you can actually roll yourself out and support. But the part is, sometimes you end up seeing even 7 or 6 people in a day.
I was going to guess 8, but
yeah, based on the hourly hours and
sure.
Yes,
but that's
But the thing is, when you do that, you're not very much effective, because you need after every, let's put it after every client, you need a break of how now. Yes, another break of, so that you can give the best attention to and the best treatment to the other. But the thing is, you end up, because of time and on the monetary side of it, you end up, every hour is occupied.
Yeah.
Yes, but for you to be effective, 4, 5 at most.
Okay, so I want to build on that a bit. So you see 4 patients who you need to see, presumably for another like 10 sessions before. So it means that if you have 4 patients today, 4 patients sign up today, and all of them you have to see them for another 10 sessions. So for the next 10 weeks, if you're seeing each of them, weekly, for the next 10 weeks or so, you will see, if you're working 5 days, you'll only see, 4 times 5 is 20? Only 20 people for 10 weeks. Yeah. That's what's possible, realistically.
That's the
if it's supposed to be
It's supposed to be like that, impactful, effective, realistically, but that's not the case.
So essentially what we are saying is that if we continue using that model for treatment, we are looking at millions of people never being able to access professional help just because it's not possible.
Yeah, that is very true.
Yeah, I'm guessing it's not really like going to the gym to do health and fitness, because they can do like 20 people at a time.
Yes, and you can focus on 24 hours. It's sometimes even it has gotten and even the process of recruiting people for group therapy, it's not a process. That's where you can see, at least in a group, you can have at most 10.
Yeah.
But now even that one is consuming in terms of time. But as you've said, not like a gym. Gym, you can focus on so many people.
Yeah.
When you go to our hospitals, you find when I sit in that office, I won't have time for break even. I'll eat my food when I'm waiting for the next client.
Yeah.
So I'm having,
Yeah.
so burnout rate is very high within our systems. So you can't sustain it. And that's why you find in hospitals, you come in, you're presenting with symptoms. I'm very quick to see, okay, this is the diagnosis. Because if I spend a lot of time on that, I won't have energy for the rest of the people. And I'll be at the...
What does that do to you as a person? Because I mean, if we all keep coming and dumping our, issues on you, and you're dealing with 8 of us in a day, is there some blowback to you as a therapist?
Or does it just make you feel better than everybody else? A lot of problems around here.
No.
I'm the same one here, isn't it?
Yeah, the thing is, if you don't have a self-care plan, you end up with compassion fatigue, where you're numb to a point of it dehumanizes you.
Mm-hmm.
You start seeing, now this is the challenge, you stop seeing people as humans, like with real problems.
Mm-hmm.
You see them as labels of the diseases.
Mm-hmm.
You're like, that's depression. Yeah, this shows like it's schizophrenia, that's bipolar. So you stop seeing the human side. So this angle we are talking about, looking at what are they presenting, look at your system, biological family, you stop focusing on that. You focus on the label. What is DSM presenting? Yeah, this is presenting. Yeah, that's what does. Because now to prevent you from getting to that compassion fatigue, it dehumanizes you.
Yeah.
You numb that connection,
Yeah.
and you see them, you're patient. And which is detrimental also to the mental health practitioner.
Sure.
Yeah.
Wow, that is, so it's really compounded, isn't it?
Yeah, it is.
It's like you're trying to resolve a problem and you might end up in a pit yourself.
Yes. So to protect yourself from that,
You-
more self-preservation.
You depersonalize,
Yes.
you just step back and you become mechanical.
Yes, which is not even healthy for
It's-
even you.
Or the person you're dealing with.
Yes, because now even the technique you'll be using, because every client, the way they are presenting, the technique is different to use. You can't use, let's say, the technique I've used to this person, even though you're struggling with depression, is the same one I will use. No, but the minute you become mechanical, this is what I'm using, the therapy technique I'm using, and this is what I'm going to use with all my clients, because I don't want to expound myself.
Could that also explain to a point why there are people who often come from encounters with therapists with the feeling like, I went in there and I came out feeling a lot worse than, when I
You heard
was
that from people?
Yeah, I hear
really?
that quite a bit. There are people who come out and so often when you also suggest that you need therapy, somebody just dismisses you. They tell you I don't want to waste my time.
Oh, yeah, that's a true one. That's, I don't need that.
I faced rejection because of that, because of what other therapists did. Someone comes to me, and even when I tell them, when I see a problem and I'm telling them there's a need for therapy, they're like, no way, I'm never going back to a therapist again. Like now that lack of trust, because you feel, I went to someone where I want to feel safe and I can get better, but I got there worse.
Yeah.
So that can happen. And so for us now, you find many people, the thing is with this profession as it's growing, with as many people coming out and talking about mental health issues, we have people who are not really professionals, but they know how to put out papers and say, I am good enough to offer this. They end up harming patients instead of helping them. So that's why we have to be, even as you're seeking help, it's good to be vigilant. Understand the credentials of this person.
Could be a future podcast topic to actually talk about how to choose a mental health professional or what red flags for the industry, et cetera. That's a different subject, but it would be handy as a toolkit just for people.
That's good. Yeah.
But I bet even if indeed compassion fatigue is a risk for mental health care professionals, even this discussion is probably good.
Oh, this is good. Yeah. This conversation.
You're welcome. I'll charge you.
I think
it's actually quite expensive. But I have 7 sessions actually planned.
Okay. I shall commit myself.
Okay.
So here's a thing I wanted you to touch on, and I hope we have enough juice in our batteries there to allow us to do this. Perhaps, So We would also like your guidance on understanding the people who are providing mental health support. What does the landscape look like? Often we hear names like psychiatry, psychologist, counselor. Sometimes we use these terms interchangeably, but people don't really know who is who. And it's occurred to me that it's often a good thing to just clarify for people as part of psychoeducation, so that when they can always know who to turn to when there is need. So that's something I would want to invite you to just provide some guidance on.
Okay, let's start with the most common, the psychiatrists, which everybody, when you say in the field, people call you a psychiatrist. In Kenya, how they're trained, they are actually qualified to give medication. And also you find there are others who are specific and provide therapy, but for psychiatrists, the main focus is on mental disorders, all these we've been talking about, where for them, it's when you go to see them, high chances of you given medication, it's very high. Yes. So
this would be like a medical doctor?
Yeah, they have been trained as medical doctors, but specialized in psychiatry.
Okay.
Yes, so they've been trained on understanding the medication someone needs and even the diagnosis part. Yes, that one. So those are psychiatrists. So then comes to where I am in, which is clinical psychologists. For us, we have been trained also in identifying assessment, diagnosing mental illness, but we can't give medication. We can't. So we can also provide therapy. We can diagnose and refer. Let's say I've diagnosed someone with bipolar. I sent that code to the psychiatrist. The work of the psychiatrist is to give medication. So that I can do as a clinical psychologist. And we can also deal with other behavioral issues happening, but now our training is really focused on mental illness. That's the major training. Now come to psychologists. There is now a difference of counselors and counseling psychologists. Counseling psychologists have gone through the same training. They can, based on the severity of the situation, they can also do that assessment. But now they focused on all other issues, behavioral issues, life challenges, stress issues. They focus on basically everything. Now comes to counselors, and in Kenya we have counselors who are qualified in terms of certificate level, diploma level. So these are the ones who now offers based on the same thing, severity. These are someone you can go to, they assess, they see this case is severe, let me refer to a clinical psychologist. Let me refer this one to a counseling psychologist. But counselors are trained to offer basic counseling. This is someone you go, if you don't know what is happening with you, you can go have a chat with them.
Is that the same as talk therapy, or is it?
Yes, that's talk therapy.
Okay.
You can go see them, talk to them, and from there, based on the severity of the situation, they can decide, let me send you. So that's the landscape of now psychology. Now we have had now recently when you hear someone say a counselor, it's better to understand what's your level of education. Because based on the level, there's some issues they can't address. If it's a severe mental illness, they can't address that. You have to refer to someone who is trained to actually do that.
Is a counselor the same as a therapist?
A therapist, it's a word which is thrown around. And
I know.
It's good to maybe clarify.
Yeah. So a therapist, mostly you refer to a psychologist, mostly. Psychologists are the ones you say is a therapist.
Okay.
Yes. Even sometimes when I don't want to break it down, I just say I'm a therapist.
Oh, okay. So it's more, it's not some technical term, it's an umbrella?
It's an umbrella term. But now for counselors, there is now that distinction, a therapist and a counselor.
Okay.
So the words, they interchange each other, but they are used interchangeably by people. But it's best to clarify and say when you're talking about a counseling psychologist, it is someone who has specialized in counseling psychology at a master's level, clinical at a master's level. So a psychologist or even a counselor can get to a level of even just a degree. But specialization, that's why you specialize in counseling psychology, in clinical psychology, that way as you go forward. But the others, the levels are even at a certificate level. This is like 6 months training. We have a diploma, which is 2 years training. But now when you go to a level of a clinical, you have close to more than 6 years of training.
What do you call someone who just does encouraging memes on Instagram?
Oh?
Someone who just does encouraging memes on Instagram. What do they call it?
Yeah, those ones now we're seeing. Now we have come to now people with lived experience. We have the mental health champions who speak about mental health, who have a lived experience, so you're passionate, you have no training in mental health at all, but you've maybe seen a therapist, you've gone through a therapist session, and you have a basic understanding of that. So those are the people you're finding online. Champions. Okay. We have the advocates who are now driving the policies. These are people you're finding them in the lawyers here. You're
an advocate.
Yes. Usually they are the people who are advocating for the rights of people with mental illness.
I see.
So you're finding, even as professional, we can get into that docket, or if you're finding someone who has a lived experience and feel there's a need of me using the skills I have to advocate for mental health. So it's good to know where now, who is one. But now we have very many people becoming very vocal about mental health. So these are the ones we say, the champions.
Okay.
They speak about it, yes.
So I think we may need to come to bring this to a close for today because of some technical challenges which we had not foreseen. We will carry on this conversation at a later date. Obviously, there is still a lot of ground to be covered. And I think for now, we will just say thank you very much for today's session. We assume, rightly, I hope, that you will still be joining us for the next session because we haven't quite covered some very critical aspects.
Yeah, we have 6 sessions left.
6 sessions left.
Yes.
Don't throw away your antibiotics too soon.
I believe our technical team agrees, isn't it? That she hasn't even started. We have so many questions for her. Yeah.
I would love, you're the best host. I would love to come. It is therapeutic for me.
Good stuff.
Well, thank you for coming.
Thank you very much.
And for those of you watching or listening back at home, again, it would be helpful if you could click like and subscribe and share it with somebody else. It is important for us to get the message out there. And right now, that's all we ask of you is to help us in that. You can go to meiammental.me to find out more. And once again, find us on most of the social media platforms. Also, meiammental will be the keywords to find us there. And in the meantime, we appreciate your interest in mental health, and we're here to find more people and more conversations like Rhodah to help us go down this path together.
Thank you. Bye-bye. Stay tuned as we continue this conversation with Rhodah Kithure, a clinical psychologist, in part 3 of this series.